First, let me introduce my team. I'm Dr. Junjie Zhang, and today the live case operator is Dr. Ge Zhen. So please, Dr. Ge, introduce your team.
On my right is Dr. Gao and Dr. Chao, and I'm our nurses, and the technician is Dr. Pan. So firstly, I want to ask the Dr. Gao to introduce the patient clinical information.
It's my honor to introduce this case. This patient is 74-year-old female. He was admitted into our hospital presenting with current chest pain for 6 months, aggravated 8 days. Her risk factors included essential hypertension, diabetes, and hyperlipidemia. Lab tests at our hospital showed her eGFR was almost normal. BNP was significantly elevated. Echo showed her left ventricular ejection fraction 45%. She was diagnosed as unstable angina, essential hypertension, diabetes, and hyperlipidemia. The baseline echo at our hospital showed her left ventricular enlargement, mild aortic valve stenosis, and mild aortic regurgitation. Left ventricular ejection fraction 45%. Baseline ECG found ST segment depression. The baseline angio showed mild to moderate stenosis, diffuse lesion in right coronary artery with severe calcification. From epicardial view and a spiral view, we could find a distal left main bifurcation with severe calcification. 90% stenosis in distal left main involved LAD and left circumflex. Syntax score for this patient is 58. According to definition criteria proposed by Professor Xiao Liangchen, the distal left main bifurcation belongs to complex distal left main bifurcation lesion. After hard discussion, we plan to perform PCI IVUS guided PCI with ECMO support for this chip case. For severe calcification in LAD, left circumflex, and left main, we plan to use vascular lithotripsy and rotational atherectomy, by if needed. For complex distal left main bifurcation, we plan to use DK crush any technique.
Because the patient with low ejection fraction, so I think use the ECMO to support this patient to do the PCI procedure. Okay. So IBP, I think if the procedure is smoothly and the ECMO is enough for this case, and after that, if we can get the good the TIMI flow, probably we can to remove the ECMO catheter after the procedure. So this is our plan for this patient. For the PCI procedure, because the LD from the ostium to the distal is the diffuse lesion, and LD and the diagonal is a true bifurcation. It's very complex. So from the right cranial view, we can see the in the proximal the LD, we can see some of the vessel is probably is okay. Probably I want to the nanizone is here to proximal LG to the left man, and then for the distal bifurcation, probably use DK crush or another two-stent technique to treat it. For the REMS, probably use the wire to protect to keep it open. I think is enough. So that's it. So this is the ECMO catheter. We already to insert it, and machine is all worker is very well. So, and from spider view, we advance the wire to the LG and the circumflex, but we advance the wire to into the REMS is very difficult because we can see the very angular in there. So I use the myocaster to support, and then use the XTR wire to advance the REMS, distal REMS. Okay, and then use the 2.0 balloon to predirect to circumflex, proximal circumflex, and the LD, proximal LD and the left main, and then I check IVUS for LD and the circumflex.
So here we can see the LAD vessel diameter is about 3.2 millimeter. And here we can see the LED and the diagonal, the plaque area is very large. The calcification angle is about 360 degrees. Then go and pull back. This is a proximal LED. And here, point is the ostium LED. And here, the area is just 2.5 millimeter square. And the plaque burden is more than 74%. And here, the vessel diameter is more than 3.5 millimeter. In distal left main, this point we can see the area is just 2.0 millimeter square, and the plaque burden is more than 87%.
Dr. Pan, what's the vessel size of the left main?
4.5.
4.5. Okay, so proximal LED is 3.5. The vessel size. EM, yeah. Actually, from the IVUS and also from the angiogram, actually there is a good landing zone for proximal LED.
Vessel diameter is about 3.5 millimeter.
Okay.
But the classification angle is about 180 degree. Then go and pull back here. This point is a ostium circumflex. And here, this point, the area is about 2.6 millimeter square, and the plaque burden is more than 80%. And here, the vessel diameter is about 4.0 millimeter. Then go on here. This is the LED and the circumflex bifurcation.
So what's your strategy after 2.5 NC balloon predilation?
Yeah, this is key for this particular case. Is diffuse lesion with severe calcification, especially from the left main to the LD. From the IVUS, we can see here is calcification more than the 330 degree. So, and because the diameter is more than 2 millimeter, so I want to use the IVUS to treat this calcification.
What's the balloon size for the lithotripsy?
From the IVUS, probably we use 3.0 millimeter balloon to prepare this lesion. So probably use the non-compliant balloon to prepare is enough for this circumflex. So here I use the 3.0 IVUS to prepare the LG and the distal nerve main.
So for this particular severe calcification case, after NC balloon predilation, we will use 3.0 IVL for the lesion preparation. So because during IVL treatment, left main will be total occluded. So we have used ECMO to support the patient. From this point, I think ECMO can supply at least 2.5 liter output from the cut compared with only 0.5 liter of IBP. ECMO is more powerful than the IBP for the circulation support. Dr. Pan, what's the length of the circumflex ostium lesions from the IVUS?
6 millimeter.
Yeah, I think it's a short.
Okay, here.
Okay. So the IVL balloon was across the ostium circumflex from the distal left main to the proximal ID and inflated at 4 atmosphere. So we have started the second round of the lithotripsy. Hemodynamic a little lower, but still stable, more than 100 for the systolic pressure.
It's good.
The balloon was looks fully expanded. Yeah. How many rounds we have performed for the lithotripsy?
3 rounds.
3 rounds. Okay.
Very good.
The shape of the balloon was a fully expansion. Yeah. I think it's effective lithotripsy for severe calcification lesions.
Is it 4 rounds?
Yeah.
Back.
Okay, from the angio, I think we get a good result. So next step, we will check the IVUS to see have we successfully opened the calcified lesions. As you can see the high OM and also the first diagonal. From the angle, it looks small vessel, but the length of the artery is quite longer, quite long. So and also supply a very large territory. So it's not a small side branch; it's a big side branch. Yeah. Dr. Pan, you introduced the IVUS image.
Lumen area is very small, and here we cannot clearly see the crack. And here we can see medial dissection.
There is at least 2 or 3 crack. Very effective laser therapy for this case.
Okay.
Okay.
Left.
So this is 2.5 NC balloon predilation.
And here I will pull back. The vessel diameter is about 3.5. And here this point, the plaque burden is not more than 50.
Good.
Yeah, maybe here is a landing zoo if we use a decay crush for circumflex.
Yeah.
So first stent, I want to use the 2.5. Is that is okay?
Yeah.
2.518 stent.
Dr. Pan, according to the IVUS, what's the stent size for the circumflex?
Maybe 3.0 is better.
3.0?
Yeah.
3.0, okay.
What's the length?
18.
18, okay.
Okay.
We prepare 3.018. Because from IVUS, actually, the ostium circumflex still very tight lesions and also very eccentric calcified lesions. So safety concern, I think 3.0 is better. I think it's longer. We can change the stent, yeah. It's longer.
Yeah.
It's 2.515. So this is a tough case and also a very difficult decision because LED, there is no good landing zoom. This is the proximal LED stand.
6.
We
8.
landing the stand at the relative normal segment from the angiogram. And avoid the distal edge dissection. Yeah. So use a stem balloon to do the post dilation at high pressure.
Yeah. 14.
That's good.
Good. Okay.
Then we can do a cine to check there is no distal edge dissection.
Yes.
Then we will switch to the distal left main with the decay crush.
Stent.
So next step is the decay crush. The first step, side branch standing. So according to the IVUS imaging, we selected the 3.0 by 18 stent for the circumflex with the minimal protruding into left main. At the same time, I think we will choose a 3.5 balloon put into the LED, which will be used to crush the circumflex stent. Yeah. And also, Dr. Ge put a jet wire protect the remus. Also, actually, it's from the IVUS. Actually, Dr. Pan, it's a high OM or remus. This is from circumflex.
8.
Yeah.
8. 9. 10.
I think VP a little lower. Yeah, you can see there is control staining at the aortic root.
Because the two balloons.
Yeah, be careful. No, I mean the aortic root. You can continuous staining, control staining there, which means the cardiac output is lower. So circumflex standing is complete. So we will check the angio and confirm there is no distal edge dissection. Yeah, it's look good. Then we will follow with the balloon crush.
Balloon crush, yeah.
Crush again.
Yes.
We should got a very good crush result. Otherwise, there will be difficulty to rewire the side branch and reballoon the side branch. Then after balloon dilation, we will do the kissing balloon inflation. So what's the balloon size?
This is 3.0.
3.0, yeah. So we'll redo the first kissing balloon inflation.
Yeah.
With the 3.0 balloon in circumflex and the 3.5 in 3.5 in LED. Why? Be careful. What's the balloon size?
3.0.
3.0, yeah.
By
Too long.
15 is a little
15.
long.
Yeah, that is a resistance.
Okay.
Maybe you can switch to
Ankle.
ankles. Okay,
good.
good. So prepare the port balloon, 4.0 port balloon. So will you pull out the jet wire before you put the stand?
Yeah, after standing. After standing, I put the jet wire.
So for the optimal left man position, I think LAO crane view is quite important. I think we have fully covered enough.
Yes.
Yeah.
Yeah.
Have we overlapping the distal?
Yeah,
I
overlapping.
think it's overlap.
If overlap, I
Okay.
think.
Okay.
So
For
before
all,
your port, will you pull out the circumflex wire?
yeah, I would.
Because circumflex we have put the stand. Yeah. No need to protect the circumflex. Yeah.
Good.
It's good. Left man stand. Yeah.
For all.
Yeah. Oh,
When we pull out the jet wire, you should avoiding the guiding tip pumping out, which will injure the osteo left man
Yeah.
stand structure, induce the longitudinal stand deformation. Yeah.
After push the balloon into the left man, and
Yeah.
then pull out the circumflex and the remus wire.
Yeah. Now after port, they will do the next step of decay crush, a secondary wiring still from the proximal cell.
Yes.
So after method standing, I think we should do the port. The port size should selecting according to the proximal vessel. Make the stem full expansion, and also port can lead to good position of the stem at the POC zoom, and also facilitate the side branch wiring because port can open the stem cell at the POC zoom. Yeah. For the secondary wiring, Dr. What's the wire position of the decay?
Yeah, for the decay crush technique, the second rewiring is from the proximal or the middle stem strut.
Still from the proximal, yeah.
Yeah.
So we will use 3.5 in the LED and still use the 3.0 balloon for circumflex.
Yes,
and do the sequential postulation for circumflex and the LED, then do the final kissing balloon inflation at a medium pressure.
Yeah. Oh,
okay.
Nice, very nice.
80.
So you see the beautiful of decay crush after first kissing balloon inflation. For the secondary rewiring, actually only one layer stand. So you can see even we still use a 3.0 NC balloon, we can very smoothly advance the balloon cross into the circumflex. So after sequential post dilation, we finally do the kissing balloon inflation. For the final kissing balloon inflation, we should keep the two balloon tip at the same level. Yeah. So from the angel, actually the circumflex balloon looks fully open, full expansion. But from LED, actually there is a waist. After port, we can do the angel, then followed we do the IVUS. I think it's a nice demonstration of the chip case we treated with IVUS guided decay crush with ECMO support. So after final casing, we haven't do the angiogram.
Okay.
Yeah, we can do angiogram here.
Okay.
Nice, huh?
Nice.
Thank you.